Good.
Okay, we're ready to go. All right, I'm going to start the broadcast now. Hello, this is Luana Bossolo with the APA Practice Organization. Welcome to today's webinar on getting reimbursed using telehealth and the new cognitive functioning G-code. And before we get started, I'd like to review a few logistics. This webinar is being recorded. So if you have to jump off the webinar, or for those who registered and are not able to stay for the full webinar or not at all, or if you're joining today, you will get a copy of this webinar in 24 to 48 hours. Additionally, if you look at your panel, there is a handout option on the panel at the bottom right above the chat room. And if you click on that little arrow, you can download a PDF copy of the webinar slides. We want to thank everyone who submitted questions in advance. We received close to 200 questions. Many questions were similar, so we will try to address as many as possible during the webinar, as well as take questions that come in live through the chat room. Now I'd like to welcome our presenters. Dr. Antonio Puente, 2017 President of the American Psychological Association, who has worked on reimbursement codes for more than 25 years. I'd also like to welcome Deborah Baker, who is a legal expert on telehealth issues in the APA Practice Organization. And I'd like to welcome Diane Padula, who is a lawyer in our Government Relations Office and an expert on Medicare in the APA Practice Organization. So welcome, everyone. And with that, we're going to start with some essential basics that are directly tied to getting reimbursed for telehealth services. And I'd like to turn it over to Deb Baker to start with that section.
Thank you. So within the past 10 years that I've been working on telehealth issues, I've noted that the use of technology in healthcare has exploded, and this is evidenced by the multitude of telehealth products and services available in the marketplace, the growing patient demand for greater access to both the providers and their own health information. There's been a greater proliferation of federal, state, and organizational telehealth policies, and most notably for me, I've seen a significant uptick in the number of member questions about telehealth and health information technology. So first, let's talk about what is telehealth. Well, the issue can be described under a number of terms. I've seen telehealth, telemedicine, telemental health, telebehavioral health, telepsychology. So regardless of whether you're referring to telehealth, telemental health, or telepsychology, using technology and providing services has clearly resonated both with providers and patients because it can offer convenience, whether you're facilitating appointments that might otherwise be missed or canceled due to scheduling conflicts or illness, but can also provide an increase in patient access to services, whether it be for patients who might be homebound or for those who live in communities that may lack access to providers or specialty services. But keep in mind, despite this growing sector or modality for providing healthcare services, this isn't necessarily meant to be a moneymaker. This isn't necessarily a mechanism for the purpose of bumping up practice revenue per se. But payers are increasingly covering telehealth services. So in order to be able to provide those to patients who are using their insurance benefits, it's important to understand what the rules of the road are. And so as a result, not only understanding what the term that's being used to describe the particular interaction, but it's also understanding how that term is defined. There is no one standard definition, and so it's important to look at the particular policy. There could be a really expansive definition, or it could be a very narrow, limited definition. It may specify only particular technologies that can be used, or not. It could also specify only particular services would be covered using technology. It may or may not limit the use by certain providers, and there may be only specific settings in which telehealth may be offered. Next slide, please. Next. Thank you. So, not to overwhelm you with text, but this is the definition of telepsychology as it appears in APA's practice guidelines for telepsychology. And the reason I provide this example is this is an example of a very broadly defined term. And the reason APA chose to use this broad term is because it understands that for the purpose of guidelines, which may be in effect for as long as 10 years, understanding that technology is rapidly developing, and so it's important to use an evergreen definition, particularly as it pertains to guidelines. But more often than not, when you're talking about payer policies and federal and state laws relating to telehealth, you're going to see a much narrower definition used. Next slide, please. So generally speaking, what is telehealth? How does it work? Typically, telehealth is going to involve a two-way video conferencing interaction between the patient who is in one location and the psychologist or other type of healthcare provider who's at a different location. Occasionally, or in certain circumstances, telehealth may include the use of email or other type of electronic communication to transmit digital images for services like radiology or dermatology. But typically, it's real-time video conferencing. That means typically telephone, fax, and email communications just for an interaction between the patient and the provider are not included in the definition of telehealth. And often telehealth may have some additional requirements. For example, it may specify that a patient has to be in a particular location. Oftentimes, a patient's home is not a covered location. In some instances, a telepresenter may need to be available where the patient is located at the time services are rendered. So it's important to check the payer policies for the individual insurance company. Next slide, please. So how do you bill for telehealth? Well, first of all, it's important to note there are no separate standalone codes for telehealth. Telehealth does not have its own set of codes. Rather, you would use the relevant CPT code that best describes the service that you provided to the patient. So for example, if you're providing psychotherapy and it fits the definition for 90834, then that would be the CPT code you use for the telehealth interaction. Generally speaking, all psychological services, with the exception of testing, can be provided through telehealth. However, often payers will ask that you use a modifier after the CPT code to indicate that the service was not provided in an in-person office visit. The two modifiers that are often used by payers is either the GT modifier, which signals video conferencing, or the more newly created 95 modifier after the CPT code, which is being increasingly used by commercial insurance plans. But whether or not you need to use a modifier, and if so, which to use, be sure to check with the individual insurance company. Next slide, please. So before we get any further, I want to take a side note and remind folks that when you're talking about telehealth, this isn't just about what does the insurance company say. It's also about remembering to be compliant with HIPAA and high-tech requirements. So if you're subject to HIPAA already, in other words, you transmit patient health information for claims or billing electronically, then you're going to need to make sure you're HIPAA compliant across your practice. This includes following both privacy rule and security rule requirements. So if you work with any type of third party that may have access to your patient's health information in order to help you run your practice, you need a business associate agreement with that third party. And third parties that would qualify as a business associate may include an accountant if you use one for your practice, if you use a billing service or practice management software, an answering service, and it may also extend to any of the technology used in delivering telehealth. So it's really important that providers use HIPAA compliant vendors and, if possible, encryption when possible in providing telehealth services. Now, there are a lot of platforms out there that use encryption or say that they have an encrypted transmission. But keep in mind, encryption alone is not enough to enable you to be HIPAA compliant. So it's important that you use applications and platforms that not only talk about being HIPAA compliant, but also offer or are willing to sign a business associate agreement. And as with all contract issues, it's always helpful to consult with a local attorney before signing a contract. Next slide, please.
Thank you, Deb. I would like to talk a little bit about the Medicare telehealth requirements now. You're going to see there's some key ways in which the telehealth requirements for Medicare are very similar to private insurance, but there also are a few that are distinctly different and are very important for you to keep those in mind when you're billing for services provided through telehealth. As Deb mentioned, for private insurance, there are no specific codes for the vast majority of the services provided through telehealth. So if you're providing a psychotherapy service via telehealth, you're using the same 90832, 34, or 37 code you would use as if you were providing that service face-to-face. Medicare for many years has covered the diagnostic interview, the individual psychotherapy codes, the health and behavior codes, and although they don't cover testing in general, they do cover the neurobehavioral status exam under code 96116. CMS also has its own G code specifically for smoking cessation and alcohol and substance abuse. Next slide, please. I'd like to add here some of the key differences from what Deb had to say about private insurance. Medicare no longer requires the GT modifier. That is a change they announced at the end of 2017, and so from January 1st on, the GT modifier is no longer used. But what you must have for your place of service, regardless of where you are when you are conducting a telehealth service, you are using 02. 02 is now the new place of service code for all telehealth services that are being billed to Medicare. Medicare does have some pretty strict requirements. It must be interactive audio and video that permits real-time communication with the patient. So you can't do anything in the sense of, say, store and forward the way a dermatologist might be looking at a slide that someone sends to them. I think the most challenging issue for psychologists, as Deb mentioned in regards to private insurance, is much the same, which is unfortunately a patient's home is not an originating site. The patient must be at what is defined as an originating site, such as another provider's office, a hospital, a skilled nursing facility, community mental health center, a number of others that you will see on this slide. If the individual is not in one of those places, and if that originating site is not in either a rural health professional shortage area or a county that is outside a metropolitan statistical area, then unfortunately, even if you have the right equipment, you cannot bill Medicare for a telehealth service in that situation. Next slide.
Thanks, Diane. I want to talk about coverage by Medicaid and private health insurance for telehealth services. Medicaid is becoming the largest payer for telehealth services in the U.S. As you know, Medicaid coverage and the Medicaid benefit plans are determined by the individual state. All 50 states have some sort of coverage for telemental health services. And the most common factors for Medicaid programs covering telemental health are that the mental health assessments, individual therapy, the psychiatric diagnostic interview, and medication management services are the most commonly covered services. And most often, coverage is limited to the following providers: psychiatrists, advanced practice nurses with clinical specialties, and psychologists. The states I have listed in this particular slide are the states that have that rate the highest, or in terms of offer the best coverage under Medicaid for telemental health services, because those states don't have any specific coverage restrictions. But it's always also important to note whether or not individual psychologists are recognized as approved Medicaid providers in your particular state before offering services to a Medicaid beneficiary. And then there's private insurance companies. Many of the larger insurance companies are increasingly covering telehealth services. Part of that is driven by the fact that more and more states are enacting insurance coverage mandates for telehealth services. Next slide, please. So this map is a visual that kind of provides a snapshot of what the telehealth coverage mandates look like. So all of the states, they're coded green, have some sort of telehealth coverage mandate in place. The light blue states are the states that don't have any laws currently in place. And then there's about 3 states that are coded a funny green and white shade. And while they have some sort of law in place, it's either a permissive law in terms of it's not a mandate for telehealth coverage, or it may only apply to a particular class of providers. But keep in mind, if you live and practice in one of the blue states, that doesn't mean there is no coverage or reimbursement for telehealth services. There just means there's no state law requiring an insurance company to do so. But as I mentioned, many of the larger insurance companies are covering this because if they're already covering it in other states where they offer plans, they may be covering it in your state as well. So it's important to check with your individual company. Next slide, please. So as reflected in the map of the previous slide, there are 36 jurisdictions, including Washington, D.C., that have enacted a coverage mandate. And so what is a coverage mandate? Basically, the language in all of these laws state that an insurance company is prohibited from refusing to cover a service simply because it was provided by telehealth if that same service would be covered if provided in person. So that's what all of the laws and all of the jurisdictions say. But after that, there's a good bit of variability. So it's important to really look at a specific state law. And some of the variability can include a number of details we'll go into in a moment. As I had mentioned, there were 3 states that were coded a little differently. Louisiana was one of those 3 states, and because its law is specific only to physicians, so it's not applicable to any other healthcare providers. And then Massachusetts and Illinois, while they have a telehealth coverage law in place, it's not a mandate. So what those laws say is that, hey, insurance company, if you choose to offer a telehealth service, you can't impose any additional requirements beyond what you would already require for the same in-person service. So those are more of an optional type of telehealth coverage state. Next slide, please. So what are the differences among the states that have these coverage mandates in place? Well, first of all, pretty universally, phone therapy is excluded from the definition of telehealth. So what this means is that you cannot rely on this particular type of state law as support for compelling an insurance company to pay for a phone therapy session. So you really need to check and see if the insurance company has a separate coverage policy for phone therapy. And coverage parity doesn't necessarily mean reimbursement parity. So what does that mean? Is that the state does not specify in its law that reimbursement for a telehealth service has to be at the same rate as the comparable in-person service, then that gives an insurance company wiggle room on how they set the reimbursement rates. But of those 36 jurisdictions, there are several states that were smart enough to include language requiring that the rates for telehealth be the same rate as that for the comparable in-person service. And those state laws are Arkansas, Colorado, Delaware, Hawaii, Minnesota, Missouri, Tennessee, and Virginia. Also, the coverage mandates may not cover all health plans. Some states may limit coverage just to the private health plans, whereas other states may be more inclusive and may include state employees' health benefits plans and even Medicaid. And then it's also important to note whether or not your state law specifies or gives discretion to insurance companies to limit coverage just to those providers who participate in the insurance company's network. therefore excluding out-of-network providers from being able to get coverage or reimbursement for telehealth services. So the devil's really in the details, unfortunately. Next slide.
Okay, thanks, Deb. We're going to get into some specific questions that were submitted by attendees, and we're going to open this up to all three of our presenters. So our first question is about coding for place of service, telehealth versus office. Deb and Diane, is this something you can each address regarding private insurance and Medicare?
Yes, as I mentioned earlier when I was discussing the material specifically about Medicare's telehealth services, for Medicare, the required place of service for any telehealth service is 02. So that's POS 02 for any telehealth services being billed to Medicare.
For insurance, for Medicaid and for private insurance, it's really going to depend because Medicaid and most private companies are still requiring the use of a modifier following the CPT code. So it's not clear whether you also have to include the place of service code. But since a lot of the private companies follow CMS on their billing policies, it's very possible that you would have to include that. So it's important to check with the individual payer.
All right, next question. What are the reimbursement rates for telehealth? Deb, you want to tackle
Again,
that one
I'll
first?
start first with Medicare. For Medicare, the reimbursement rates for a telehealth service are the same as if the service was provided face-to-face.
And in those 8 or so states I mentioned that include reimbursement parity in their telehealth coverage laws, the reimbursement rate should be the same as the in-person rates. However, in a majority of the states that have coverage mandates, they don't necessarily specify the reimbursement rate issue. So it's really going to depend.
Great, thanks. The next question, so how can a psychologist bill Medicare for psychotherapy under code 90834?
On the CMS 1500 form, you would be doing almost everything exactly the same as you would for an inpatient, an in-your-office visit. The only difference would be instead of using the point of service for the office, you would be using the 02 point of service. Everything else on the 1500 form would be exactly the same.
Okay, great. All right, let's move on to some other questions. Do I need to be licensed in the state where the patient lives in order to provide teletherapy? Deb, you want to take a crack at this?
Sure. The short answer is yes, unless you qualify for a licensing exemption under the Psychology Practice Act in the jurisdiction where the patient is at the time services are rendered. It's ultimately, because it involves your licensure, it's ultimately a risk management issue. So we always strongly encourage our members to check with their professional liability company for risk management advice on that particular issue.
Deb, I have another one for you. If I'm on insurance panels in my practice, can my telehealth practice be completely self-pay?
The answer is going to be it depends. If if any of the patients you would see as part of your telehealth practice are covered by an insurance company or any of the insurance companies for which you participate as an in-network provider, then no, you cannot be self-pay for those patients because your contract extends to your full practice, whether you're seeing those patients in person or seeing them using technology.
So are services like Skype and FaceTime acceptable for teletherapy usage?
Generally speaking, I'd say no. As I'd mentioned earlier, while there are platforms that talk about using encryption, and while encryption is preferable, it in and of itself is not a silver bullet to ensure that a provider is HIPAA compliant. And everybody who's subject to HIPAA as part of the security rule really needs to conduct an individual risk assessment, looking at the potential risks and vulnerabilities that may exist in your practice in terms of your patient health data, both in terms of storing it, transmitting it, and disposing of it. And so part of what we always encourage is thinking beyond just Skype or FaceTime.
So what other platforms are out there that are HIPAA compliant, and are there costs involved?
That's a really good question. There are other platforms that are out there that are trying to be as user-friendly as something like Skype or FaceTime, with which a lot of folks are familiar, because they see the increasing need for healthcare providers. While APA doesn't formally endorse any particular products, here are some examples of companies I've seen in the marketplace that not only talk about being HIPAA compliant, but are also willing or offer a business associate agreement. Some of those include Zoom, HIPAA Chat, Cloud Visit M, the letter M, Theralink, WeCounsel, Doxy, and fees will vary based on an individual provider's usage of the platform, and it depends on the individual company. But given the higher scrutiny that HHS, and more particularly its Office of Civil Rights, which is charged with the enforcement of HIPAA, given how they've increased their enforcement efforts, it's really important that healthcare providers are ensuring that they're taking the steps needed to be compliant with HIPAA's requirements.
Okay, great. So we're going to switch gears now and turn things over to Dr. Puente to talk about the new cognitive functioning G code. Dr. Puente?
Thanks, Rhonda. As you may know, there are almost 9,000 CPT codes, and for psychologists, there are approximately 50 or 60 that are available to us, roughly split evenly into what we may call assessment and intervention codes. We obviously have wonderful psychotherapy codes, but they are intended to be used for emotional disorders, or if you will, DSM disorders. What are you to do if you do cognitive intervention for a different kind of problem? Well, effective January 1, 2018, we have a new code, and that code is 97127, which is replacing the prior 97532. It has a much broader definition, as we'll see in a moment, and is developed to capture the concept of a therapeutic intervention for all types of cognitive functioning, primarily associated with someone that has a specific type of disorder, for example, a neurological disorder. Unlike the other intervention codes that we're used to, namely the psychotherapy codes, and for that matter, the H&B codes, this is not a time code. This is a per session code. Next slide, please. As you can see from this slide, this is the specific descriptor that's provided, and it includes any kind of therapeutic intervention for cognitive function. And as you can appreciate, it involves anything from attention and memory, which are the most typical ones, to executive function and problem solving. The idea is to develop any type of compensatory strategy that increases the performance of an activity. So specifically, you're looking for the manipulation of a schedule, remembering a particular task, and so forth, so on. This is a one-to-one patient contact. It is not intended to have group interventions or any other form of computerized non-engagement of the patient situation. Next slide. Next one is, I'll turn it over to Deanne. Diane?
Yes.
Could you tell us a little bit about the Medicare response to the new G code, which is always a challenge to those of us in the practice world?
Well, a response to the new G code, a better way to put it would really be to say a response to some of the issues that we brought to their attention that led to the new G code. It was pretty apparent very quickly that even though the new CPT code was going to have a higher value, the way in which it was written and would be used was going to be an issue for psychologists. Unlike some of the other healthcare professionals that have provided various cognitive functioning services, psychologists are the ones most likely to be using it in a way that requires multiple services. And what would have happened in terms of the difference between the code people could use in 2017 and the new code for 2018 is that because it would have been one unlimited use, psychologists would have actually been seeing a decrease in their reimbursement because they would no longer be able to accurately reflect the number of times they provided the service. And so by bringing this to CMS's attention, fortunately we were able to convince them that there needed to be a way to address this discrepancy, that there truly was a difference in the way psychologists were going to be using the code from the way other healthcare professionals would be using the code. So their answer was to create G0515, a G code that can be used by psychologists performing cognitive functioning services that will be reimbursed at the same level as the previous 97532 code and can be billed multiple times. So since psychologists on average tend to bill this code for at least 4 units, they will be able to continue to do this with the new G code and be paid at the same rate that they were previously. So overall, it may be a little bit more complicated. It's one more thing that people have to keep track of, but it's a much better solution than had they been forced into using the new CPT code and limited to billing it only once, despite how many times they had to actually provide the service to the patient.
So before we go on, Diane, are you then suggesting that if you are working with a private carrier, most likely you will continue using 97127 new code? And if you're working with Medicare, you should be using the G0515 code. Is that correct?
I would say that we only know at this point that you would use the G code with Medicare. Definitely there should be some outreach to the private insurance carriers just to verify how they now want this service to be billed.
Thank you very much, Diane.
Okay,
Next
great.
slide, please.
Okay, and I just, before Dr. Puente gets into some very important information on how these codes are formulated, I just want to mention we do see the questions being submitted live, and we are going to get to some of these questions you are submitting live right after Dr. Puente goes over some important coding information. Dr. Puente?
So many psychologists ask the age-old question, how does all of this occur? How does the changes in coding and reimbursement that affect me day to day occur? Well, I have to tell you that after 15 years representing APA and 8 years being on the CPT panel, it's much like sausage making, very complicated. Let's take a look at the next slide. Instead of providing a detailed analysis of how codes come to be, which in and of themselves take approximately anywhere from 2 to 8 years and go through unbelievable process, let me just explain very briefly one aspect of that, and that is the reimbursement side, the relative value unit. You can see the multiple steps requiring analysis, consideration, and vetting, not only internally by APA, our staff and our colleagues, but also by, if you will, sister societies. Very complicated, very strenuous process, and it's indeed one that we have super great staff working on it under the direction of Randy Phelps. Let's take a look more specifically as to this process, and that is shown in the next slide. Again, I wish I could tell you that this is as simple as just asking for a code, asking for a reimbursement rate, and getting it. It's very complicated. It involves science, diplomacy, patience, and sometimes just good old luck. The practice organization usually identifies psychologists and neuropsychologists primarily through a random sampling of membership. And those are the ones that are actually sent the surveys once a code is determined. People always ask us, who sets these values? Well, in reality, we do. So we decide based on these surveys how to respond. And once the survey is given to us, you have to fill this out yourself. This is not a survey that can be shared with others. And once you complete it, it is submitted along with hopefully many others. Then that is discussed, analyzed, and finally presented to the AMA RUC panel. And those folks then begin to ask very, very challenging questions to determine what the final goal of what they think it should be. Whereas we often believe that our analysis should be the final resting spot for the reimbursement rate. What turns out that most times the RUC panel takes a very different perspective. Sometimes 75% of the presented value, sometimes much less. The negotiations are fierce, demanding, and challenging. The goal, in many ways, is for us to defend psychology and make sure that each of us get reimbursed appropriately. But it's not as simply as asking. Now, once we get the value, that value then is sent over to CMS, which decides whether to accept it or not. Almost always they do, but sometimes they simply just sit on it. And once that RVU value is obtained, we then have to wait for Congress to determine what they call the conversion factor. The RVU value is then multiplied by this conversion factor to determine the final reimbursement for each of those 8,500 codes. A very complicated process requiring time, intensity, sweat, blood, and tears, a great deal of staff, and as I mentioned, diplomacy and some luck as well. Now, let's turn to the many questions that you've submitted in the last few minutes that we have with you this afternoon. So, Luana, can I turn it back to you?
Yeah, thanks, Tony. So I'm going to pull from some of the questions you all are submitting, and this first question is from Karen, and it's Medicare related, so this one's for Diane. So Karen's question is, if you can't bill Medicare because the client is homebound or not covered because it is retirement coaching, can I bill as a private payer or bill as private pay if I am a Medicare provider?
I would recommend that they contact their Medicare administrative contractor and ask if that would be considered a non-covered service that could be billed to the patient if they provide an advanced beneficiary notice. The advanced beneficiary notice, otherwise known as the ABN, is something that you give to the patient to let them know that it may be something that Medicare is not likely to cover. It's not entirely clear just what category this falls into, because the service itself, meaning essentially psychotherapy, is something that Medicare would cover under different circumstances. So the key part of the question is whether the fact that it is being provided via the telehealth mechanism, but the patient not being an originating site, therefore not making it eligible for reimbursement through telehealth, does that then turn it into a non-covered service? So again, I would recommend they contact their Medicare administrative contractor to verify that.
Okay, great. This next one I believe is for Deb, and it's from Carol. Some states are passing legislation to enable the provision of services in states that acknowledge reciprocality. And she says she can't remember the technical name of the act. How will this affect provision of telehealth services?
Well, that's a really great question, Carol, so I thank you for submitting it. I think you may be referring to the Psychology Interjurisdictional Compact. Assuming I'm right, it's the shorthand name is Sai Pact. That is an initiative that is being that was developed and promoted by the Association of State and Provincial Psychology Boards, which is the regulatory body for all the psychology licensing boards in the US and Canada. So what this would do is it would create a legal mechanism among those states that adopt the Sai Pact legislation. It would be an up-down vote. They couldn't tinker with it. And therefore, all the states that adopt the Sai Pact would become part of the Sai Pact Commission. And the Sai Pact would seek to do two things. One, would allow psychologists who then obtain the appropriate telepsychology credential, I believe it's being referred to as e-passport, would allow a psychologist in a Sai Pact state to provide telepsychological services to patients in other Sai Pact states. The other benefit of Sai Pact is it would make uniform for in-person temporary practice 30 days. There's a lot of variability among state laws right now as in terms of temporary practice. So this would make that more standardized and easier for psychologists. Assuming that that is in fruition and you, Carol, are in a Sai Pact state and the patient whom you'd want to see is in another Sai Pact state, that would address the licensure interstate compact issue of telehealth. The other issue you would still need to deal with is is the payment issue. If the patient is using insurance benefits, what are the payer policies around that? And if you're in different states, which states coverage law applies. And then the other issue would be is making sure too, if you're required to comply with HIPAA, are you using HIPAA compliant or technology that enables you to remain HIPAA compliant and taking other steps that are needed to provide good care across state lines.
Thanks. The next question is from Jane. So are you saying that telehealth is not available for patients who are homebound?
Well, I'm going to jump in and talk about it outside of Medicare. I'm not saying that. What I'm saying is that in private insurance, you may be able to provide services to patients in their home. What's important to note is, one, if your state has a telehealth coverage mandate, is there anything about originating sites similar to Medicare that would exclude the patient's home or limit the settings where telehealth services could be delivered? Or does the specific insurance company have any specific policies around that? CMS has very specific requirements around that. Private insurance has more discretion, but it's always important to look in two different places, both whether your state has a law that mentions that in any way, and then what the individual insurance company's policies may be.
Deb, but you're basically
Luana,
suggesting, basically what you're suggesting is, as much as we like to have telehealth as an open concept, we have to follow the limitations associated with HIPAA and the related concerns, as well as state regulations.
I agree. Even though technology is opening the doors in terms of breaking down access barriers, telehealth in and of itself triggers a lot of different requirements that healthcare providers need to abide by. It's not just, it's state laws, it's federal laws, it may be individual insurance company policies. If you're providing services within an organization, what are the organizational policies? And then also, if you're talking about practice across state lines, then you're triggering a whole host of other issues. And then fundamental to any time you provide healthcare, patient privacy and security considerations. So yes, it's not the wild, wild west where it just kind of opens the floodgates and is enabling providers to just willy-nilly provide services to anyone, anywhere.
And I want to add just one point about that in regards to Medicare. Unfortunately, one of the real constraints that Medicare faces is that when new services are added to the program, they're typically added through federal legislation. So it is not easy for Medicare to try to make very many changes to what they're being given when it's coming through federal law. And that may be one of the reasons that despite repeated requests from many healthcare societies, they have not been able to expand the original list of originating sites to include a patient's home.
Right. So switching gears slightly, we have a few requests from attendees who are asking Deb if you can repeat the platforms you mentioned that are HIPAA compliant. Let
me again issue the disclaimer that APA nor APA Practice Organization is formally endorsing any particular product. So I really encourage members, when you check out these various platforms, please do your due diligence and make sure you're finding something that fits your practice needs. But generally speaking, when I talk to members about using technology, the two main things to look for in your search is when you're looking at a particular platform website, is it saying it's understanding what HIPAA compliance requires, and that as a technology platform, it needs to abide by HIPAA's requirements as well? And does it talk about offering or being willing to sign a business associate agreement with you, the healthcare provider? Some of the platforms I've seen that purport to do this are HIPAA Chat, Zoom, Cloud Visit M, Theralink, WeCounsel, that's WeCounsel, and Doxy, DOXY. Most platforms are going to charge some sort of fee, whether it's a subscription fee or a per use fee, but they're also offering some peace of mind in terms of helping you to remain HIPAA compliant. So I like to think of it as you get what you pay for. So if you're not paying for access to a video conferencing platform to provide services to your patient, then you can't expect to get much assurances in terms of that technology helping you remain HIPAA compliant.
Deb, I want to ask a question that a lot of my peers have asked me. Are you sure I can't use Skype, or for that matter, FaceTime?
Most folks out there in the telehealth world, the telehealth policy world, and in the legal world, and even the ITS world, really strongly encourage providers to rethink the use of Skype and FaceTime. While those are ubiquitous and readily available on almost any device, the only thing that either offers is encryption. But encryption in and of itself does not enable you as a healthcare provider to be HIPAA compliant. There are other things under the security rule that a healthcare provider needs to follow when using technology, such as having an ability to have an access log, who is accessing your account, an audit trail, or being able to know that that platform will alert you if there is any sort of data breach. And there is nothing that has led me or others like me to believe that Skype or FaceTime are HIPAA compliant in that way, or intend to hold itself out to be HIPAA compliant. While they may be encrypted, again, that alone I don't think is sufficient to ensure that a provider can remain HIPAA compliant. So I strongly discourage members from using that as the platform for communicating with patients. Communicating with friends and family, great. Even communicating with colleagues about CEs, perhaps. But I definitely look at other options for providing services to patients.
And one more time, are you really sure I can't use my telephone and get reimbursed for that?
I'm pretty certain no. But check with the individual insurance company. You may find one that will cover phone therapy in certain situations, but I wouldn't include phone therapy in thinking about telehealth. They're separate issues.
Thank you.
Okay. I'm going to jump now to some of the questions that were submitted in advance. How can telehealth communications by phone or text be encrypted for confidentiality?
Wow, nobody gave me any easy ones.
Okay.
So there are apps available that either provide encryption for phone calls or text messaging, or can encrypt those types of messaging and other data, whether they're stored on a device or in transmission. But as I mentioned before, encryption on its own is not the silver bullet. You really need to think from a bigger picture about text messaging generally. When is text messaging appropriate? For which patients? Why? A lot of payers aren't going to cover text messaging. And as we mentioned before, phone is not necessarily going to be a covered service. Predominantly, if you're going to engage in telehealth and you want it covered by a payer, it's going to be through video conferencing. So you may be able to find some encryption apps, but I don't know that alone makes it a suitable modality for providing services to patients.
Okay. I want to actually jump back to a question that was submitted by Wendy. And Wendy asks, how is group therapy handled with telepsychology with a HIPAA compliance system used in their state of licensure?
Again, I had listed some platforms out there that have been developed specifically for the healthcare market. I would explore with those platforms the functionality for having more than two parties involved in an interaction. I'm sure from a technical standpoint, it is possible. But again, as for any group session, you're going to need to make sure you have the appropriate informed consent, where you are specifically addressing the limits of confidentiality, both because it's a group session and because technology is involved. And so there are obviously going to be certain sorts of limits to patient confidentiality as a result of folks being in different locations, and as a result, the psychologist isn't going to be able to secure the environment where everyone's in to make sure it's private and confidential. So again, I would talk with a particular platform to see how best to log in more than one patient for a particular session.
We have a question for Dr. Puente from Jennifer. And Jennifer asks you, could the 97127 code be used by a neuropsychologist for a feedback session that involves detailed discussion of compensatory strategies for cognitive weaknesses?
As with every insurance company and carrier, it's just determined by basically the determination policy. What is typically used is an extension of the 96118 code, and make sure that you document that information. So in other words, you provide an indication of the feedback session, what you have shared with the patient, and the compensatory strategies. That may also be useful in carrying the information not only about the results of the testing, but the suggestions for how to proceed with intervention.
Okay. So while we're on codes, I'm going to jump back to the question that was submitted that is on everyone's screen. How do you code for a 90834 or 90837, et cetera, Skype or similar session? Will Medicare pay for these sessions?
It's a bit of a complicated question. I'm trying to see just what the individual is getting at. You can provide individual psychotherapy sessions through telehealth and Medicare. Skype, however, is not HIPAA compliant and would not be the type of platform that you'd be able to use. So if you're doing it with the proper platform that's HIPAA compliant and the patient's in an originating site, then you would simply be submitting a claim with the appropriate CPT code, depending upon the length of the session, 90834, 37, or 32, And for place of service, you would be using the 02 designation.
Let me add to that as well, Diane, and that is, depending on the insurance company, as a rule, most carriers will pay for all types of, if you will, interviews, including the neurobehavioral status exam, all types of intervention, and as far as we know, almost never any type of psychological or neuropsychological testing. That may change as we move forward with the technology advancing, but at the present time, again, most telehealth is limited to interview and intervention.
Okay.
That's a great summary, Tony.
Okay. How can folks find up-to-date rules for telehealth on a state-by-state basis?
So there are a variety of places that are actively tracking this in real time. I know that there are telehealth resource centers around the country that specifically target telehealth advancements and policies in particular states. Also, the American Telemedicine Association has a legislative tracker where it's actively tracking any and all telehealth related legislation in a current legislative session. So that might be a good place to start to see if there's any kind of movement in your particular state.
Great. I'm going to jump back to a question that was submitted live, and this is from, I believe it's Talia. And she asks, if I am moving to a new state and want to continue to see some of my current clients via telemedicine, do I have to join the local insurance network in my new state, in addition to remaining in network in my current state? And is there anything else that I should be aware of?
Well, I'm going to take this one. I think there's several things that need to be done. If you're moving to a new state, first of all, are you getting licensed in your new state? Secondly, are you maintaining licensure in your previous state where your previous patients are still residing and located for when services are being offered? So licensure is a critical component, and licensure in both jurisdictions is a critical consideration. The other part is whether or not you join the panel in your new state is going to be up to the particular insurance company. Ultimately, the question is going to be for the insurance company through which the patients are using their benefits to cover or pay for these telehealth services. Will they continue to see you even though you've moved across state lines? And what kind of changes would they have to make in your credentialing? Would they continue to recognize you? Would they make you reapply because you have a new address? The first thing, though, is make sure you're licensed in both jurisdictions. The second thing is I would check with the insurance company, because if you're moving to another state, but it's part of a plan that is regionally provided, you may not have to get recredentialed. But if it's more state specific, you're going to need to find out from provider relations how best to facilitate your ongoing status as an in-network provider if you can.
Okay. So Deb, then could you take this last question that was submitted in advance? It's on everyone's screen. If a patient is moving out of state for college, can we conduct sessions through teletherapy? And what if the patient is moving to a Sai Pact state?
Again, this really is a licensure risk management issue. If the patient is moving out of state for college, I'm assuming the psychologist is remaining in the jurisdiction where the patient's family lives or where the patient returns for breaks from school. The question is really going to be, assuming you're not licensed in the jurisdiction where the student is going to college, then the only way you could do that without getting additional licensure is if that other state has some sort of temporary practice provision that would enable you to do so without having to obtain additional licensure. Otherwise, you would just have to limit it to those times when the student is back in the jurisdiction where you're licensed to practice, because unfortunately, your license to practice psychology is limited to the jurisdiction that issued the license. If the patient's moving to a Sai Pact state, it is possible, assuming that you are in a Sai Pact state and that, more importantly, that you have obtained the required credential, which I believe is the e-passport, that would empower you to be able to provide teletherapy or telepsychology in Sai Pact states. That's going to be an important credential to obtain, because that is the process by which all the Sai Pact states will be notified who is practicing virtually into their state, so that those licensing boards can continue to fulfill their consumer protection mission, which is knowing who's providing services into their states to their consumers. So maybe is the answer to both of those questions.
Okay, great, thanks. So we'd like to draw everyone's attention to a number of resources that are available on telepsychology on APA's website. If you downloaded the PDF of these slides from the handout section in GoToWebinars, you can click on the links on this slide to access all of this information, including the articles from our Up to Code column that cover specific information regarding codes and the billing values and how these codes come into being. Additionally, we have more resources on billing and reimbursement at apapracticecentral.org, and Dr. Tony Puente's website, psychologycoding.org, has a whole slew of resources as well. And if you're having billing problems or other problems with private insurance or Medicare or Medicaid, we have staff that can speak to you and can offer some consultation. If it's regarding private insurers, contact our Practice Legal and Regulatory Office, and the email address is on this slide. If it has to do with government insurers, please contact our Practice Government Relations Office at practicegovrelations@apa.org. And again, if you downloaded the slides, you can just click on these email addresses to send staff an email. Thank you so much for attending today's webinar. Thank you to our presenters. A link to the recorded webinar will be emailed to all folks who registered within hopefully the next 24 hours, possibly sooner, within 46 hours. And we do like your feedback on these webinars, so there will be a link to a survey when you get the webinar in your email, and we hope you will fill it out and give us your feedback so we know how to improve and enhance these webinars for you. Thanks so much, and have a great day.